Pheochromocytoma is a rare, usually benign tumor that arises from the chromaffin cells of the adrenal medulla, which produce catecholamines like adrenaline, epinephrine, and noradrenaline, norepinephrine. These tumors can lead to excessive secretion of these hormones, causing a variety of clinical symptoms, often related to the cardiovascular system. Epidemiology. Pheochromocytoma occurs in approximately 0.2% of hypertensive patients. It is most commonly diagnosed in individuals between the ages of 30 and 50, but it can occur at any age. Men and women are equally affected. Pathophysiology. Catecholamine secretion. The tumor secretes excessive amounts of catecholamines, either intermittently or continuously. This leads to the activation of alpha and beta adrenergic receptors, resulting in systemic effects. Genetic basis. Up to 40% of cases have a hereditary basis, often associated with genetic syndromes such as multiple endocrine neoplasia type 2, MAN2, von Hippel-Lindau disease, neurofibromatosis type 1, succinate dehydrogenase, SDH mutations. Symptoms and signs. The clinical presentation is highly variable. Classic symptoms occur in spells or paroxysms and include 1. Cardiovascular symptoms. Severe hypertension may be sustained or episodic, palpitations or tachycardia, orthostatic hypotension, sometimes due to volume depletion. 2. Neurological symptoms. Headache, intense and throbbing, sweating, profuse and episodic. 3. Other symptoms. Anxiety or panic attacks, weight loss, hyperglycemia due to catecholamine-induced insulin resistance. Classic triad. 1. Headache. 2. Sweating. 3. Palpitations with hypertension. Triggers for symptom flare-ups, physical exertion, stress, certain foods, e.g. those rich in tyramine, such as aged cheese or wine, medications, e.g. beta blockers without alpha blockade, tricyclic antidepressants, decongestants. Laboratory tests. 1. Biochemical testing, plasma-free metanephrine's most sensitive test, 24-hour urinary metanephrine's and catecholamines. 2. Elevated levels of these markers confirm the diagnosis. Imaging. 1. CT or MRI, preferred for locating the tumor. Most tumors are found in the adrenal glands, but 10% occur extraadrenally, paragangliomas. 2. Functional imaging, for unclear cases or metastasis detection, e.g. MIBG scintigraphy, PET scan. Genetic testing, recommended, especially for younger patients, bilateral tumors, or family history. Complications. Hypertensive crisis, cardiac arrhythmias, stroke, multi-organ failure in severe cases of catecholamine excess. Treatment. 1. Preoperative management. Alpha adrenergic blockade, e.g. phenoxybenzamine, controls hypertension and prevents intraoperative crises. Beta adrenergic blockade, added after alpha blockade, manages tachycardia. High salt diet and volume expansion prevents postoperative hypotension. 2. Surgical resection, laparoscopic adrenalectomy, standard treatment for adrenal pheochromocytomas. Open surgery may be required for large or invasive tumors. Careful monitoring during surgery to manage potential hypertensive crises. 3. Postoperative monitoring. Regular follow-up with biochemical testing to detect recurrence or metastasis. 4. Treatment of malignant pheochromocytomas. Rarely, these tumors are malignant and require additional therapies like chemotherapy, targeted radiation, MIBG therapy, or newer systemic treatments. Prognosis. Most patients experience significant improvement after surgical removal of the tumor. Recurrence occurs in about 10% of cases, therefore lifelong follow-up is necessary. TAPSCRA. Differential diagnosis, hyperthyroidism, panic disorder, primary hypertension, carcinoid syndrome, hypoglycemia. Summary. Pheochromocytoma is a potentially life-threatening condition if left untreated, but it is highly treatable with appropriate biochemical diagnosis, imaging, and surgical intervention. Its association with genetic syndromes underscores the importance of comprehensive evaluation and family screening.